Okay, while we're talking about early breast cancer, this is a good segue to our next study, TAILORx study. TAILORx has been practice changing since its initial publication back in 2018, where a majority of patients with early node-negative disease and recurrence score of less than 25 did not benefit from additional chemotherapy. This has now been the standard of care for these patients. But patients with higher recurrence score, our options here in adjuvant settings is often TC times 4 or anthracycline-based treatment. We've always wondered in clinical settings who's the right patient for anthracyclines because we have to be mindful of the side effects that come along with this. Jame, with all this in mind, thoughts on the recent updates from this study and its findings?
Thank you, Rahul. So I'm someone who did a lot of clinical trials and grew up in the NSABP culture, where anthracyclines are not the most favorite agents. We try to de-escalate anthracyclines if not appropriate. I think this is a really good study. So, especially node-negative patients, we try to avoid anthracyclines unless really indicated. So this particular study actually looked at subset of patients, TAILORx, who had a recurrence score more than 31 or less than 31, who received an anthracycline-containing regimen versus a non-anthracycline-containing regimen. So what they found was in patients with recurrence score more than 31, there is an improvement in distant recurrence-free survival. Now, so recurrence score more than 31, an improvement in recurrence-free survival when they received anthracyclines. And they saw that in patients who are under the age of 50 or older than 50, premenopausal or postmenopausal, and most of the benefits were in tumor, which was more than 2 centimeters. And higher the recurrence score, the benefit was higher. So that is really interesting too. The key question is, are we going to use this tomorrow in our clinic? And let's just think, if I have a patient who's 52, she has a 3 centimeter tumor, and it's grade 3, and it's not negative, I'm planning to give chemo, then should I use this tool to make a decision? I think I'll have a conversation with this patient about TC versus an anthracycline-containing regimen, or TC times 6 versus AC followed by T or TAC regimen. If the patient says, I want everything to be done, I need to know the risk and benefit, I probably listen to the patient advocate. He said something like, more information is helpful. That's what she said. More data, more information is helpful. I may use in those subset of patients. If the patient says, give me more data so that I can make the right choice, then I may use it. But if he asks me if I'm going to use for every patient, probably not.
This is certainly very intriguing, especially this question comes about when we are treating premenopausal who are node positive but have low oncotype score, where the struggle is OFS plus AI beneficial, or rather chemotherapy itself is beneficial? Now, in your practice for hormone receptor positive breast cancer, whose current scenario gets anthracycline in adjuvant settings?
What I use is more than 4 nodes. Based upon the Tic-Tac data, we know that that's a subset of patients who benefit. So more than 4 nodes, I'll say you should get anthracycline. But let's just say if the patient is younger, let's just say we have a 32-year-old with 3 nodes. I'll say for that patient, the long-term risk is relapse from breast cancer rather than a cardiomyopathy. So then I'll say you should consider anthracycline-containing regimen. But overall, more than 4 nodes, I'll say you should get anthracycline.